Good morning, I am Giulio Antonelli. I am a gastroenterologist from Rome in Italy, and I would like to thank editors and reviewers of Endoscopy Journal for the acceptance of our paper in the journal. On behalf also of all my co-authors, which are many because it was a multi-center trial, and I invite you to read the whole article, which is found on the Endoscopy page and on PubMed. The title of the article is Endocuff Vision Improves Adenoma Detection Rate in an Organized Screening Program, Results of the ItaVision Randomized Control Trial. So, briefly, we know that colorectal cancer incidence and mortality is reduced by screening colonoscopy. But we know also that there is a very high still reported neoplasia miss rate during colonoscopy, that it has been reported in a recent meta-analysis up to 25%. So it is known that this neoplasia miss rate is due to two main factors, which is mucosal exposure and recognition failure. Recognition failure is when I have the polyp on my screen and I cannot see it because I'm tired, because I am distracted. And this can be addressed by artificial intelligence, for example, and we are seeing that is very useful for this. Mucosal exposure is the failure of exposing the whole colonic mucosa, so missing polyps because, for example, they are behind the fold and I cannot see it. So, to increase mucosal exposure, many add-on devices have been proposed, and we study in this article one of them, which is called Endocuff Vision. Endocuff Vision has evidence for increasing adenoma detection rate, especially in endoscopists with a low adenoma detection rate. But in the screening setting, where we have an increased and enriched population with more neoplasia because of the FIT test that these patients undergo first before undergoing colonoscopy, we know that we don't know if Endocuff Vision actually has a role and if it actually increases adenoma detection rate. So this was the aim of our study, so analyze the impact and the role of Endocuff Vision in the Italian nationwide colorectal cancer screening program. So we underwent this multi-center trial in 13 centers across the whole of Italy in 6 regions in adults that undergo colonoscopy after a positive FIT test. And we randomized patients to undergo standard colonoscopy or standard colonoscopy plus Endocuff Vision. And our primary outcome, of course, was adenoma detection rate, and we also stratified adenoma detection rate of the endoscopists. So we had 3 groups of endoscopists: low detectors, medium detectors, and high detectors, to see if there was a cohort of endoscopists where Endocuff Vision could be more useful. So we randomized nearly 2,000 patients, nearly 1,000 for each of the 2 groups, and the results were interesting because we found that globally Endocuff Vision increased adenoma detection rate by nearly 8 points. So we had a baseline ADR of 40%, and in the Endocuff group we had 48%, so it was increased. And it was increased also for advanced adenoma detection rate, and the location in which the adenomas were mainly found in addition was the distal colon. So this also is interesting. But then, as I told you, we stratified our endoscopists by their baseline adenoma detection rate, and the results were even more interesting in this sub-analysis because we saw that Endocuff Vision actually benefited only low detectors. So endoscopists that had an ADR lower than 33.3%. In this category, adenoma detection rate was increased by 15%, so from 26% to more than 40%, while high detectors, so endoscopists that had a baseline of nearly 48% of ADR had no increase in the use of Endocuff Vision. And this result was consistent for all polyp sizes and even for advanced adenomas. So actually low detectors found many more advanced adenoma with Endocuff, while high detectors didn't find help from Endocuff Vision. The other interesting factors is that adverse events were not increased in the two groups, and that Endocuff Vision was used with success in 97% of the patients that were randomized to Endocuff Vision. In the only small number of 3% where Endocuff was actually removed was because the patient had pain usually, and usually because they had a narrowed sigmoid colon for diverticular disease or a fixed sigmoid colon. So these are the main messages of this of our paper, and I hope that if you have found it interesting, you will go and read the whole paper on the Endoscopy journal page. Thank you very much for your attention. Bye bye.